This?
My name is
How about I keep them in a tray?
Carney. I'm an ENT surgeon in Adelaide, and I'm one of the board members of APOS, which is Asia Pacific Otolaryngology Surgical Training. And it gives me great pleasure to welcome you all here today from what's presumably a lot of different countries. And with COVID-19, obviously our ability to run live hands-on dissection courses has been quite restricted. So what we thought we'd do for you today is do a Zoom live cadaveric dissection. And who's the person going to be doing the dissection is no less than Professor Richard Harvey from St Vincent's in Sydney. Richard's also a board member of APOST and probably needs no introduction. He's one of the most famous rhinologists in the world with an extensive clinical and research track record. He's got massive number of publications, a ridiculously high H factor, and he's been responsible for some of the leading papers in rhinology, over the last decade. And I think those of you that have ever met Richard know he's a very enthusiastic speaker. And I can't think of anyone better than to take us through this cadaveric dissection today. Now, this is going to be followed by sort of lectures and hands-on cadaveric dissection in Bangkok. For those of you that are in Thailand, that is where the one place that Professor Konkat Sidvons is going to be running a dissection lab sort of immediately after this. So welcome to everyone. You can see from the screen, Richard's got some image navigation up and running. And we're going to start by running through the scans, just really identifying the anatomy, giving you some tips and pearls of what to look for in the CT. And then Richard's going to start with a complete sphenoethmoidectomy, what we would regard as a full house FESS on one side, and then run through a lot of other advanced rhinology techniques. And I think by the end, this cadaveric head will be completely dissected on both sides. Now, we've actually got a lot of time for this. I think Richard's hoping to do it all in an hour, but I think we've got a lot more than that, Richard. We've actually got 4 hours of dissection time allocated should you run over. So I'll hand over to you, Richard, now. And what I would like to encourage people is put your questions and answers for Richard through the Q&A section, and I will pass them on. And any questions that we can't answer during the dissection today, we will answer via email over the next few days. So welcome to everyone. Welcome to Richard. And so I'll pass over to Professor Richard Harvey.
Thanks very much, Simon. It's a very kind introduction. It is exciting to do something live and a live dissection, and we're going to try to make it as interactive as possible. Very kindly joined by two ENT specialists in training, Alex Zhang and Cara Morris here in Sydney. They're in the lab with us. They've got their own dissection heads, so we're sort of running like a mini course here. We're going to run this bit live, and I'm going to go through the head first of all on the CT scan and go through this MPR view, the axial coronal and sagittal views. I'll take you what I think is important. As we go back here in the coronal plane, and I'm going to drag the scan back, there's really only a handful of things, Simon, I look for, and I'm really open to what other people think. The first thing is that I start here and I look at the orbital wall just to make sure that the orbital wall from front to back, here is the level of the nasolacrimal sac, but from that point backwards, there is no natural dehiscence, no natural area where the orbit is bulging medially into the ethmoid. And the reason I look for that, from all the way at the back near the optic nerve, orbital apex coming forward, there's no area where the orbit is inadvertently hanging into the ethmoid. Now, that could be congenital, could be post-traumatic, but it's just something you can't predict. So that's a great reason why to look at the CT scan. The next reason to look at the CT scan is look at the anterethmoidal artery, and you can see in this person, often referred to as Kennedy's nipple. Kennedy's nipple is just that area. You can often see it on a cone beam. You can't see the medial rectus and superior oblique, but that's about where you'll find it. or the other place you'll find it is just as you go past the end of the globe. So you can see the globe ends here, and then just as you finish the globe, that's about where the anteromortal artery canal will be. I might move this sagittal line out of the way, Simon. I think it's getting in our way for seeing that. So there you go. There's the anteromortal artery canal. Now, some people might call that hanging. To me, that'll just be off the skull base. And we'll find it, and I'll show you how that's not hugely at risk, but it's certainly sitting on the sort of bone and just outside the bone. As we go back, I then look at the skull base. So here's the skull base here, and I just want to see to myself, is there some weird orientation of the skull base? Is it asymmetric? I'm not a big fan of heavy Kiros measurements and classifications. I'm not sure if that really helps the surgeon. You just need to make sure that from the level of the sphenoid, the skull base is essentially symmetric on both sides, and it is a big square box. It's not a little diamond or a triangle with the apex vertically, and I'll tell you what I mean by that. So a relatively symmetric skull base, and if you said to me, what's a low skull base? But at the level of the anteromortal artery, if the skull base is above the midpoint of the orbit, then that's about normal. If you see it at the midpoint of the orbit, or lower, then that's essentially a low skull base. Once again, we'll find the skull base, so it's not a huge issue for me. But I do like to then just have a quick look on the sagittal. And look on the sagittal up here. The skull base starts in the planum, or the sphenoid roof, and then slopes up and becomes the posterior table. That's pretty much the orientation for everyone. And like looking at the orbital wall, you just want to make sure that you don't have someone who's got a fracture of their skull base or something unusual there. This is a very normal looking skull base through this whole area. So that's my view. I don't count the cells, Simon, inside the sinus cavity. I don't try to work out the variable anatomy. I don't try to find pathways and clefts and spaces. I mean, you may be able to do it here on this head, but I really think that doesn't help a surgeon. It certainly doesn't help a surgeon when there's significant pathology going on, or there's a situation where we have previous surgery going on. Now, on that note, I'm just going to find my Freer, and let's go into the head. We'll go on to the live view now, and tell me when you've got the live view up. But maybe before we leave, was there anything else, Simon, that you'd like to see on the...
No, I mean, the anterior mortal artery is the one thing that most people often skip over, and it's where a lot of people come into trouble, and also inadvertent, dehiscences, but also the anode cells. You want to just check that you don't have an optic nerve, and I know yours is well lateral. Do you use the CLOSE acronym?
I must admit I don't. I certainly like that. I think as a trainee, it's a great one to learn. But I don't really find it. There's some things in there that I just think are interesting and fascinating, like an anode cell. Like counting the number of frontal cells you have. They help you avoid misorientation of being in the sphenoid, or the posterior ethmoid, or in the posterior ethmoid when you think you're in the sphenoid and things like that. But I'm not sure they're critical, in my mind. If I was to teach the critical or the absolute basics, making sure the skull base is intact, the orbital wall's intact, and knowing the position of the anteromortal artery. These are the critical ones,
Yep.
Okay.
Right.
Should we go?
We've got the view of your
camera
experts there, and
perfect. Do you have the endoscope view yet?
I can't see anything resembling an endoscope.
It's coming up. I'm here stroking the mucosa with my Freer, ready to go.
Right.
It'll come soon.
That sounds good.
And so what I'm going to do, first of all, I mean, you called it a full house FESS, but I'm going to take us through, what a simple OMC operation is in my hands.
Yep.
And I'll show you, then I'll just convert that to a sphenoethmoidectomy cavity, and then we'll go through and I'll show you what we do in the frontal. But I'm going to stop and use the other side, Simon, to take us through some basic stuff, like how do I manage an SPA artery or SPA ligation in someone who's never had sinus surgery, just comes in with posterior epistaxis. How do I do a transnasal sphenoidotomy and in the approach for a sphenoid? And you and I spoke about, maybe doing a prelacrimal approach, where you don't need to do any sinus dissection to get into the anterolateral maxilla.
while we're waiting for your screen to come up, I think there's obviously a bit of technical issues with your endoscopic view. How do you prep the nose? So you've got actually a live patient rather than a cadaver. What's your standard preparation before you actually put a blade to the mucosa?
So I use a topical solution of 1 in 2,000 adrenaline and 1% ropivacaine. And literally the minute the tube goes in, they get placed in the nose. And I really try very hard placing the patties in the nose not to cause any bleeding. You know, the whole purpose of putting the topical cottonoid pledgets in the nose soaked in that 1 in 2,000 with ropivacaine is to really vasoconstrict the nose and do it tightly. Then I let everyone set up.
We have an endoscope view there. In fact, we've got it, but it's just not the main screen. And I'll keep going, and then once it all sets up, then you'd be surprised how many minutes are lost. You know, just between the minute the tube goes in to the time you've got the patient set up and everything draped and ready to go. Right. And then what I do is I take out the patties, and under direct vision, I then inject the lateral wall of the nose, and the septum, the floor, wherever I need to go. And I do that injection with 1% ropivacaine, 1 in 100,000 adrenaline, and I put tranexamic acid into that as well. And maybe we can share our recipe later on. Yep. And I don't do that so much for hemostasis, but I do it for pain relief and for bleeding control, ooze control. Now, you've got my view up now, Simon? We do. This is great.
Okay, so here's the floor of the nose. We're going to start on the left-hand side. Now, the first thing people often ask is, how do you get the middle turbinate to sit right? What you don't do is just crack it holus bolus. The best one is to put a freer in, bring your freer down to where the coronal part of the middle turbinate becomes the sagittal part, and do little microfractures there. Can you see how I'm just fracturing?
Yep.
Fracture, 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 and you've got to keep going. You're not going to go into the brain. Fracture, fracture. And there you go. And look at it now, how it sits, hinged on this line that we've fractured all the way from the coronal to the sagittal. Now, if you create some bleeding in the real-life case, look where the ooze is going to go. It's just going to disappear down here. It's not going to get in your way, and that's a really important part of it. The next thing is, there's lots of different ways of doing an uncinectomy, right? I'm not going to profess for doing one way over the other, but I do like doing through the backbiter technique. Now, when you do the backbiter technique, though, it's important to try to get it mobile so you can actually see where the uncinate and anterior fontanelle join the nasal or frontal process of the maxilla. And as we go back here, I try to slide down as low as I can. Now, look how low I am on the middle turb. I'm really at the junction of the upper 4/5 and the lower 1/5. Now, you can see there as I've come back, I've seen the natural ostium just there. Can you see that? Yep. I'm going to come through once more. And no more can I go now, right? That is it, right? But it's like one of those fortuitous cases of just come on exactly where the os is, right? But look at where the os is, the level. And the other thing too is if you can't see it in real life because there's edema here, when you poke your ball probe in, don't poke it here. You've got to come really forward and then you're in, right? Because the next maneuver you want to do is to stretch backwards. By stretching backwards, you create some space for you to get your next cutting instrument in. And the next cutting instrument is going to be simply a straight through cut, and we're going to go cut, 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 all the way back. And the reason I stretched back and up, Simon, is I don't want to stretch the mucosa and pull the mucosa off the roof of the maxillary sinus. That's a real common maneuver I see happen. And then as we come down here, we're going to bite through this. So I get back to about here. I always like to leave a little stump. Don't bite too close to it because you will get a little bit of bleeding and then you'll leave yourself too close to the bone. And then back I come now with the backbiter along the top edge of the inferior turbinate. And there you go now. You're
taking that horizontal part of the instrument.
Exactly. And I take the inferior bit first. That makes so much sense. Really commonly I see people do sinus surgery, they do this, and then they start doing the upper uncinate, and they create bleeding onto their field. So if you ever watch me operate, I have this general principle of doing things on the inferior and posterior aspect first, and I leave the superior and anterior areas till last. So if I have a choice, I'll do the inferior posterior uncinate. Now, and then I'll do the superior. I think it was Aldo Stam once said that you've got to get your uncinectomy right, otherwise you make the rest of the surgery very difficult. I think that's very true. We're going to pull this uncinectomy, this uncinate out at a 90-degree angle, and we're going to now to separate it from the side wall. And as we go around now, it has to stop there. I literally can't do it in that plane. And then I'm going to come through here and detach it now. Alex or Cara, can I borrow another straight through cut? I think mine's
there's interesting. Jim Palmer did a study looking at reasons for revision sinus surgery and found that 2/3 were due to incomplete uncinectomy.
Well, it just sets you up poorly, doesn't it, for the whole case?
Yep.
Now, here's a good case. If you've got a little bit of uncinate left over, using a kerrison, but you see how I've opened up the window of my kerrison just a little bit, right? I haven't got it like this, because if you do this, you'll create a huge trough of exposed bone and tissues. But I'll do this little bite here, little bite here. Now, just creating that space, I can't tell you how better that'll make the actual opening here. So let's go and do a quick tidy up. I think if anyone's never seen me operate, once again, you'll notice that I actually haven't taken any tissue out with my forceps. And we'll talk about why the bone's moving there in a second. But I don't remove anything with my through cuts. I literally just crunch and gobble. Now, once you've got here, now we've maximized our opening, right? Because we have what is the back of the lacrimal sac and periorbita here, right? That's what you should see if you've taken the uncinate right out. And it's very common. The lacrimal bone's very thin here. You'll see this little barrier. But that's a great landmark because you know then that this is going to be your lateral limit. Now, let me take you through then. Here's a bulla, but before people go to the bulla, sometimes you won't see that in real life. It'll be altered, surgery. The only thing I go looking for is the roof of the maxillary sinus. So here's the roof of the maxillary sinus. I can touch it. If my mother's life depended on it, I could say that that is the floor of the orbit right there. So that means I need now to find the medial orbital wall. Now, whether you go behind the bulla, I like just to go up through it. It doesn't matter. What you're trying to find now, in my mind, is the medial orbital wall. And let's do a couple of through bites here. We won't try to do anything more with the through bites than that. We'll then get a straight through cut and we'll take the floor of the bulla off. And then we might use a little bit of kerrison action here and we'll take the rest of the medial wall of that bulla. Kerrison's a great instrument, very safe, that's why I love using it.
What size kerrison? Is that a 2 millimeter?
This is a 3, but I like a 2 because a 2, Simon, in my mind, rarely blocks the shaver up. Even though, quad carts and I guess some of the newer shavers and type A aggressor shavers from Olympus, these ones rarely get blocked now.
Yeah, and the 2 millimeter, is that the 45-degree angled forward?
70 degree, yeah, 30 or 70 rather than the 45.
And it is,
and I like that because the 90, the keel gets in your way, like the heel of the kerrison.
It's so much nicer than the Hayjack Koffler punch.
Yeah.
Which I know I was originally trained on. It's just such a big, chunky instrument.
Okay, so here we go now. Now we have this lovely view in which we can see orbital wall, medial orbital wall, and orbital floor. Can you see the orbital floor here? There's the orbital floor, Simon. Yep. That's becoming medial wall there. So when I touch it, see how you get mass movement? That's called Cohen's sign. It's Noam Cohen from UPenn, very famous. Just a sign. Whenever you see the whole mass movement of the wall, you know that you're on the orbit there. Really, really common. Great thing to see when you're suddenly dissecting and all of a sudden everything moves en masse like that. Now, you know what? This would be it, Simon. I'd make sure that maybe I might take this uncinectomy up a fraction more if I was just going to do an OMC procedure. But if I had to do an OMC procedure,
which cell
this would be it.
there? You just moved a cell. What was that?
Oh, that's the agonasi, but uncinate. They're all the same thing. So the uncinate just becomes the medial wall of the agonasi. But if I was just to stop my operation now, because all I was doing was OMC, I would do that where I separate the cut edge of the uncinate, which becomes the agonasi, from the top edge of the bulla, because you don't want to create iatrogenic frontal injury here. But that'd be it. That'd be a simple OMC. Now let's go through and just convert that now to a sphenoid ethmoectomy. You cannot look or follow an air cell path through this space into the sphenoid. And gone are the days where you see people flick back and forth. That's really not done anymore, I think, in modern rhinology centers. Most people say, okay, here we are now. The posterior ethmoid's here. This is the retromaxilla and posterior ethmoid. If you have a look at a T here, can you see this T up here?
Yep. And then
T ends here, and then maybe a Y it is. You've got a branch that comes over here and a branch that comes over here, so covers the posterior ethmoid. You just want to go above that, and you make an opening through here. We'll then open up that coronal part of the basal lamella or middle turbinate. You can see my Y even clearer now. So here's the Y. Now anything hanging over the maxilla, see that? That can all go, because all it's covering is the posterior ethmoid or come retromaxilla. And so many times I see people leave all this intact, and then they end up having this sort of two-tunnel phenomenon, we call it, where you've got a tunnel down into here and then a tunnel down towards your sphenoid. Now, the next thing we're going to do is we're going to just nibble this across until we can see the superior meatus. And look where we are. At all times, Simon, I've got the floor of the orbit on view. It helps me orientate to make sure that I'm not going to be too high in my dissection. Now, it almost seems comical when you're doing a cadaver dissection. You think, oh, you can see it. But I can't tell you enough, if you're really doing sinus surgery on people who need sinus surgery or tumor surgery or something else, it's very common that you won't see anything more than just the orbital floor. All the normal anatomy is occluded by disease, polyps, various things. Now, what I want to show you now is we've got the orbitoethmoid plate, as it's called by Professor Kalesh. That's the posterior ethmoid. This is the middle turbinate, and you can see when you wiggle it, this structure doesn't move. Can you see that? This cleft, Simon, is the sphenoethmoidal cleft.
Yep.
This is the superior meatus. This is where the posterior ethmoid drains into this cleft. And now we're looking straight ahead at the superior meatus. The sphenoid, the superior turbinate now, if you said to me, how much do I take? Now, when people get confident in their sinus surgery, they start to over-resect things. Like they come up here and chomp, 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 chomp. You only need to take a tiny little bit of this just so you can expose the natural os.
And there is olfactory epithelium in
there. Yeah, absolutely, absolutely. Absolutely. And of course, you'll get away with it with people who don't have olfactory epithelium to start with. But the more they have, look where the os is, right? You can see how little of the superior turbinate I really needed to resect, right? So once, it doesn't matter, if you couldn't see the ostium, right, just pretend the ostium's not there, I would just simply look at the orbital floor, I'd take a line coming across and say, that is my safe entry point. If I just poke here, not even knowing where the os is, at or below the floor of the orbit, I will always be safe. When I poke in, I just simply poke in, turn around, and I stretch down, Simon.
Yep.
And then in doing so, I then set myself up to go now superior and lateral. That's correct. Superior and lateral is where you want to go. You don't want to go inferior and medial. Inferior and medial is an old sort of neurosurgeons thing where they, didn't know where they were going through translabial.
The artery if you go in for it.
Yeah, well, yeah, not a big deal if you do, but you haven't even opened your opening and then you've got bleeding, right?
Yep.
And the only thing I want to find, like a mastoid surgeon, I want to see where the normal anatomy is. I want to find what's called the corner pocket. So here you come here. I've chased that roof up now. So I can actually see what is the sphenoid sinus, the roof of the sphenoid sinus, the optic nerve. That then makes that medial orbital wall, because that's the lateral wall of the sphenoid. You agree, Simon?
Yep.
If that's the roof of the sphenoid, that makes that skull base. It has to be skull base, right? Can't be anything else. But it also means, Simon, then that if that's skull base and that's skull base, that can go.
Yep.
Has to go. And you see, that can go. And that can go. So all of that can go.
And the lowest part of your skull base is posterior.
Yeah, exactly. As long as you know where the skull base is, that can all go. Now let's go back now, and I'm going to do what I call running the ridge. So once I've got everything set up, what I try to do is I try to run the ridge. And running the ridge is now not just dipping your shaver in and twizzle sticking it around, is actually running the ridge of all of these partitions, not the middle bit. You don't want to demucosalize it, but you want to see the ridge come up, across, and down onto the turbinate. Can you see that? We'll come up here, up, down, and down onto the turbinate. You agree?
Yep.
Up, down, and then down onto the turb. Up here, up, down, down. Now, you can see here that it's going to be skull base, right? Because it's coming right across. See that? So it comes up across, and then across the skull base and down onto the superior turb. So you know, when you do that, that you've got the complete ethmoid opening. And it should be square. For most people, it should be a square opening. Now, I am going to, just for the sake of doing a little bit more ethmoid here, I'm going to do a Jim Palmer, just bite the front wall business. Just because I want to see a little bit. I don't want to swap to an angle. I just want to show you the rest of the... and we'll leave a little bit of mucosa here for a Carolyn's window. So here we go now. You can see where the anterethmoidal artery is going to be. And then I'm going to leave it at that. So that is a sphenoethmoidectomy, Simon, where...
Can you actually see the artery there, Rich?
Yeah, I can. Up here. And we'll get a better view of it in a moment.
You can see what that is.
So remember I said...
You can see that pulsating.
Yeah, but it's not that impressive, And one of these things that, if you looked at that scan beforehand, Simon,
yep.
That artery was just really sitting on the bone. But I tell you what, it's important to acknowledge where it is, because I see some people, they know it's just sitting on the bone, and then they start looking for it down here, 2 centimeters away. If it's sitting it's sitting exposed like that on the scan, this is what you'll see. It's just sitting on the bone itself. So here we are now. That is a sphenoethmoidectomy. We've preserved the T, so the Y has become a little hemi-T now. We've preserved the medial turbinate. We've preserved the superior turbinate. You can see the full length of the orbit from the lacrimal bone all the way through back to the orbital apex. And you can see the ethmoid roof all the way forward coming up into the frontal sinus. And you can see the edge of the ethmoid internally going from the medial orbital wall onto the roof, down onto the turbinates, up and around and down. It is a box, just like it is. And it's surprising there are people whose cavities sort of end up becoming triangular like this, because they don't really chase those partitions and never really find it. And if you actually find it, it makes it much quicker, much more straightforward. Now let's go now onto the other side. And there were a couple of things we thought we'd talk about here. Say you get a posterior bleed, how do you find the SPA? So let's go and do my same technique. So I would come in here, I would make my little fracture. I feel like it's got a tiny bit of memory still. There you go, very close. Then we're going to get a backbiter. So what I do in those situations is that it's actually very useful to do a very limited antrostomy. So 1 backbite, 2 backbites. We'll sit here now. I'm going to get my ball probe. I'm going to stretch a little bit. You can see I'll come in the front and then stretch back. You can see it's obviously done already. Now, when you're doing an SPA, it's actually a good idea now to take this back a little bit tighter now. You actually want to go all the way back till you feel the bone. I can feel it.
That's important, isn't it? That end of that fontanelle.
Yeah, you want to really see it. We want to feel the bone a little bit closer than you would in standard antrostomy. I don't do antrostomies really smaller than this. This is standard. You know,
you're not a fan of the conservative middle meridional antrostomy.
Yeah, person probably doesn't need operation if they're having something smaller than that, in my opinion. But I do realize that people have various philosophies of mini FESS. Okay, so here we come down now, right? So now what I do here is I essentially I get down here and I find the subperiosteal plane. I'll just get rid of the fluid. Now I'm going to show you the easiest way to do an SPA. All you do here now is you just go straight back to your eustachian tube. Can you see that, Simon?
Yep.
And then with the freer, you just sweep up on the bone.
And there's that ridge that has got a name.
There you can see it now.
Yep.
You can see where I'm being held up now.
Yep.
It's going in. I like the crista. I'm not convinced the crista is the be-all and end-all of finding it. I think one of the things you can do as a surgeon is just go low. And if you said to me, you know, what do I do in real life? I'll show you what I actually do in real life. It's okay, guys, leave it. Is I actually come in here. I'll show you what I do. In a real life case, I'll leave this in here. And I'll leave the sucker in like that. Can you see that?
Because usually it's filling up with blood, isn't it? You need something to drain.
Yeah, yeah, exactly. You've created a poor well. So I'm actually going to leave the sucker in like I would in a real life case, so you can see how easy it is to work with just your sucker parked in that pocket. It's a great tip if you're ever doing any sort of SPA work. Now, it's really important. I want to show you how big the SPA actually is right here. It's a big vessel, right? It's not something that's small. And patients I've taken back who've had them done elsewhere and are still bleeding, it's almost always they've misunderstood like exactly the size of the SPA. So here we go now. Now if you come up here now, you'll find the bone at the top part of the sphenoid. That's your SPA. And of course, Simon, the aerated cell behind me is the sphenoid.
Yep.
So that's the entire SPA. And I would say that probably in about half the SPA ligations I've seen done is that it's usually only a part of that. So here we are now. We'll see if we can actually just dissect around the whole thing. Because if we do an SPA, I might as well show the Vidian canal, right?
Yeah.
So here we go now. I try very hard actually to try to get onto that. As you can see, I'm searching for that plane. I don't want to come off it, and I'm sort of coming off it. We might actually then come with a...
Because there's another canal up there, which often people think is the Vidian, which isn't. First one you come to is often the
palatovaginal, yeah.
Okay.
Yeah, we're going to show it here in a moment. That's a good call, Simon. Yeah, it's very true. So there we are now, right? That makes it really obvious, right? Let me come through now. I'm just going to divide that with a pair of... I love Metzenbaum scissors. And Mel, who's one of our lab nursing team, has left one out for me. It's very kind. Thank you, Mel, if you're watching. And we're going to divide that all the way through. So if I was doing a Vidian urectomy, I'd divide the whole SPA like that. This is the little septal branch coming across.
How many clips do you put in your SPA?
I often just bipolar it.
Okay.
Yep. So there you go now. So here we are now. We've got our... And you can see I've intentionally cut all the way through to the posterior choana. Do you see that, Simon?
Yep.
And I kept cutting that little septal branch that's coming across the face, right? So it's very important, right? So I did that. Now, I would just bipolar that now. You can usually leave yourself enough of a stump here that you can bipolar it. Yeah, but I think if you're absolutely right, if you had any problems, you put some clips on it. If I'm anything more medial, or my apologies, anything more lateral and proximal to the SPA foramen, like out here in the infratemporal fossa, I do put clips on at this stage. And I use a medium wet clip applicator through a laparoscopic 5mm adapter. It's an Ethicon product. It's for laparoscopic work, but it works very well down the nose, and it's just an auto loader. No conflict of interest there.
And
okay.
Why? I think it's important to emphasise that you don't use monopolar. Because if you use monopolar, there's some important nerves there that you could fry and end up with problems.
Simon brings up a really good point. If you don't appreciate it, you won't understand that the descending palatine nerve, is what Simon's alluding to, is just here. I'm going to fracture this off, although you don't need to. Obviously, I'm doing it to show you where the descending palatine nerve is. As Simon said, it is very close. So here it is here. That structure down there. Can you see that on your screen, Simon? Yep.
And it is
we've got a beautiful view in the lab from the 4K Olympus station. I don't know if you can see all that, but there it is there. You can actually make out even the cadaver here, the nerve here and the artery at the back. Can you see that?
Yep.
Yeah, so there you go. So that's the descending. So just as Simon said, if you were to use a lot of loose monopolar there, you could easily pick that up. So let's pull this back now, right? So this is then the PPF. Can you see the PPF here?
Yep.
And then as we come up here, Simon, you'll see, just as Simon spoke about before, is the palatovaginal. So the palatovaginal is this little canal, and you can see it. It's sort of coming at 90 degrees. Can you see that? Now, a lot of people think this is the Vidian, but it is just a little palatovaginal. You like the little hook on that instrument? Wow. It's been used in the lab before, hasn't it, Simon? So, and I divide that palatovaginal, and as Simon said, it's easily mistaken for it. It actually runs at right angles, and after you divide it, you'll then see a really nice Vidian canal, and the Vidian canal is like a real trumpet coming towards you. And I think that hook's just perfect for me to divide the Vidian nerve, Simon. And let's see if I can leave a little stump, and you'll see the perfect trumpet. There you go.
Are you a
There's
fan
your Vidian
of
there.
posterior nasal nerve sections these days, or you still?
No, I did those for a while, and I've gone back to Vidian neurectomy. Yeah, so that would be my take on that. So there you go. There it is. There's descending palatine. The terminal branches of the SPA, the palatovaginal, and the Vidian. What about, and there's of course sphenoid through there.
So it's important to notice if you can't see into the canal, it isn't the Vidian.
That's right. I think that's a really good point. Let's talk about just a transnasal sphenoid. So if I'm doing a pituitary operation, I don't actually do a resection of the through the antrostomy and posterior and anterior ethmoid. I will just go transnasally. If I have an isolated fungal ball of the sphenoid sinus, or an isolated lesion in the sphenoid sinus, I will go transnasally. When I go transnasally, one of the first things I do is I find that junction point. Now, it's slightly operated on here, but I find there's my superior meatus there. Can you see that? So I've got my freer, Simon, in that superior meatus, and then literally with one movement, I just push that out of the way. Can you see that?
Yep.
Now, when I push it out of the way, I then actually like to get a kerosene and do a little bit of a posterior ethmoidectomy through the superior meatus. And I'm doing it so I can sort of see the sphenoid, the orbital wall. Let me do that again. I'll just put my suction in.
There was a question which I missed, unfortunately, Richard, which was, what are the different branches of the SPA, and you need to identify them all before you clip them?
What are the parameters?
What are the different branches of the SPA?
Oh, there's so many. I think those studies that Nick Jones did and Daniel Simeon showed that there was so many. Like you can have up to, I think it's something like 8 or 10. I think Simon. What was the?
Yeah, I think the vast majority of people don't just have one.
Yeah, they have 2 or 3 standard.
There's a descending branch, and there's also the septal branch, which goes inferior to the sphenodosteum.
I got it? So, I've done my little posterior ethmoidectomy through the superior meatus, so I could see this structure here, Simon.
Yep.
That's my medial orbital wall. I then would go in here, stretch down, and after stretching down, I then, with my upcuts, exactly as we did it on the other side, I go seeking out the so-called corner pocket, the junction point of the...
People get very scared doing this, but you don't need to, because up until the orbital roof there's nothing you can damage there, is there?
Yeah, that's right. That's right. It's like finding the facial nerve in a mastoid. Once you find it, there it is there. That skull base here, I can take that. That means this thing here can go, is this skull base. But it's very hard to know, I think, even a cadaver, let alone when there's disease around, Simon. So here we go now. There's obviously cellar, retroclival recess, carotid, lateral OCR, optic nerve. This is the corner pocket. Finding this is like finding the sinodural angle in mastoid surgery. It just sets you up so beautifully to know the anatomy. And you can see no checking with IGS is required. And I do like, see how I've done, I haven't sort of pushed my superior turban around too much, Simon. I have remained going through it. And that's because I use the posterior ethmoidectomy done through the superior meatus as part of my then sort of cavity and a half, so I can have my camera in there and work and do things as well. And it becomes then a functional space. I haven't violated the principles of getting a non-functional sinus cavity. And I've still opened it up from orbit to middle turbinate or the lateral boundary of the olfactory cleft. Now, Simon, what was the other one? We talked about doing a pre-lacrimal. What about I show very quickly a Carolyn's window, and then we'll come back and do pre-lacrimal? What do you think?
Yeah, so who was Carolyn?
So Carolyn Orgain was a fellow of ours about 5 years ago. And she was great. She published a whole lot of papers with us. And we started this technique where we essentially make a little flap. It's been modified over the years. But we take the flap all the way up. I do this with the monopolar diathermy. And I come all the way forward until we get to here. This is the piriform. We then drop down. With a monopolar, it's a little slicker, and scratching it out with a...
Use those little sharp needle monopolars.
I use, Megadyne 0016 AM. It's just a sort of a fine needle point. It's got enough length on it. Once again, no conflict of interest there. It's just the one I like to use. You can bend the tip. So you often see our videos, Simon, the tip's bent at 45-degree angle.
And
so I've taken...
Angling the tip makes it so much easier.
I completely agree. Like when you inject, right?
Yep.
So here we go now, and you just get straight down to the bone, which is the lovely part about doing it. Now, I take this flap all the way forward. It's not like an auxiliary flap, a little mini flap technique. I really do like to lift the whole lateral wall off. And then you pull it down. And so it's a very broad inferior base like that. Can you see that?
Yep.
And I really come right up to the piriform. It really helps a lot to do that, to really take out the piriform. You've got to get down straight to bone. Then what we're going to do is we're going to use one of the high-speed drills. This is definitely a technique that has been really born out of the new drill technology that's come out across all sort of equipment providers in the last few years. The high-speed drills make a big difference to really being able to remove bone quickly and smoothly, especially with a diamond. I'm not a big fan of using a cutter in the sinuses, and that's just because when I use a diamond, I get great hemostasis. So I hope the drill sounds doesn't bother you too much. But the first thing I'm going to find, like we do in a lothrop, is I'm just going to find out here, and we're going to find that the periosteum, whether it be over the lacrimal sac, and everyone's a little bit different here, so you have to sometimes drill more bone in some and less in others.
How big is that burr?
4 mil.
4 mil.
Okay. So let's take this out laterally, get us some space. I want some space. That's what I'm after first. I'm just going to turn the water up. I usually have the water quite a fair way up when I do this.
And I mean, I'm with you. I don't use a cutting burr anymore. Just the coarse diamond, and there's several different ones that people prefer. I quite like the coronal latresi burr, which works quite well.
Okay, good. So what I want to show you here is just this. You can see I've got a little bit of periosteum exposed. Once you've got a bit of periosteum exposed, we know that's the side wall of the nose. So, knowing that periosteum is there, we're going to take this triangular bone out, which we call Ritter's triangle. Ritter's triangle is the triangular bone between the middle turbinate, the periosteum, and in front of the frontal recess. And you just keep going back until you hit the frontal recess. And it's not just a little bit of bone. So it's not like the techniques where it's just a bit of a kerosene action, right? Mm-hmm. It is like a lot of bone here. You really got to do it with a drill.
Kerosene will only get you so far.
Exactly, exactly. It really is something. But you can see how quickly it develops. And I don't do any frontal sinus dissection before this, right? I really do this and then nothing else. I think I've lost my suction, unfortunately. And do we have a little brush here? Working with a cadaver, always the way you're going to end up with a bit of a blocked sucker.
So someone said if we don't have a nasal drill, what do you use?
Shouldn't do the technique.
Okay.
You should work with angled scopes.
Somebody's also said that, they've requested that if we can record this. I think this is being recorded.
You bet.
FESS can confirm that hopefully we'll be able to put this on the website later.
Fantastic. I think the Olympus team here and their team, and they're recording it, so I'm sure that'll be available. And if you go to our YouTube channel, I do have a sort of a whole lecture and instructional about Carolyn's window and the steps we take in a few videos. So that's certainly another place you can find it.
And there's also some good videos that Richard's made on the Olympus Academy website.
I might just get someone to get me a 20 mil syringe, only because I blocked my sucker with cadaver bone paste. It's just going to make the rest of the dissection a little bit underwater. It's actually fine from my perspective, because now that I know where I am, right? So you can see this, Simon?
Yep.
That's where we've stripped our flap from. That's the periosteum there. There's the middle turbinate. Can you see that?
Yep.
And all you're doing is you're just removing the bone that's in front of that area. And it happens very, very quickly. But you can see it's not just a little bit of bone. So when someone said, "Oh, how do I do it without a drill?" This is not. This is a technique for when you have a drill. Now, can you see where I am? And you'll see this is why it's just something you don't do with just a bit of a kerosene action. But it happens very, very quickly. It's the beautiful part about having high-speed drills.
You think
Roy
Cassiano could do it with a chisel?
I'm sure he'd give it a go. But you see here, one of the things that we always get whenever people drill is that one thing to stop, I think, yourself doing as a dissector is when you're doing drilling, don't hark back to trying to follow the sinus cavity. Stay with what you know. There's periorbita, there's middle turbinate, the frontal recess is behind us, right, Simon? So you don't need to follow the air cell tract. All we need to do is drill the bone that's in that space.
The further anterior you are, the safer you are.
Exactly. That is one of the golden rules, right? And so I'll suction in rather than drill and suction. So look how I stayed anterior, right? I think a lot of people, the minute they saw the frontal recess coming up, they'd want to then somehow connect it. But that's not what's important. Actually getting the bone right up here, staying really anterior, as Simon said, is what's important. And it means then that at the very end of your dissection, you're going to end up coming up to the frontal recess. And often that mucosa is inflamed and bleeds, where in real life, the actual dissection below that is beautiful. It's all bloodless. It's just a bony drilling with a diamond high-speed burr. And so here we go now, Simon. We're just going to drill the rest of this off here. So you can see I've got that coming up. I'll get a shaver to do that. And I think that's pretty good. We might just put a shaver on now. And let's see if I can just... And if you imagine, well, this frontal recess has very few partitions in it. But if you had a whole lot of partitions, it's not a problem. You would just simply use your quad cart, your straight, to do the dissection. Can I get the 70-degree scope up here in a moment?
Couple of questions.
Look at me going out here, just straight with a quad cart, Simon.
Yep. Couple of questions. Right? What's the anterior limit of the drilling?
The periosteum or the front wall of the frontal sinus.
Yep. And the Riedel triangle, how do you spell it?
Richard's triangle.
Richard's triangle.
Ritters. R-I-T-T-E-R-S.
Okay.
Ritter's triangle is this triangle here between the periosteum, the middle turb, and in front of the frontal recess.
Yep.
Now look at this, Simon. Though, what a great! I've got my 0-degree scope on, right? Look how I can see the skull base. Look how I can see the posterior table. 0 degree. Almost see the anterior table. There it is there. You can see it at the lip of my 12 o'clock. You agree?
Yep.
So it means then you can get a curette. And I probably here I might use a baby Hoseman here, or like I've got an articulating punch, and I would make sure, but you should be able to almost place a curette, a straight curette in the apex of the frontal sinus. That is a Carolyn's window. What you do then is you return this flap up the back wall, and then you normally have a tiny bit of exposed bone in the frontal recess itself, and I use a little free graft from the posterior. That actually heals really well. You might think that by taking more of the mucosa down, you create more problems. It's the opposite. The bigger, the wider your flap, the less congested, the better it heals. And then, so here, Simon, then I put a little free graft just here.
Yep.
And you know what? It doesn't matter if you get a little bit of scarring across here. You've done a fantastic draft 2A through this Carolyn's window approach. And although I started doing this on tumours and various things, it's essentially how I do all frontal sinus surgery, where I'm not doing a Lothrop now, because it just makes it so quick.
Did you develop this technique after you wrote your textbook with Rod Schlosser?
Yeah.
So
yeah,
because there's another question: is which textbook should we be reading? I mean, I think that the textbook that Richard and Rod Schlosser wrote many years ago now is an excellent starter. But I'd encourage you to go to Richard's YouTube, because a lot of these new contemporary techniques are there on his video channel.
Yeah, if you said to me of the textbooks that are out, the Witzka-Fockens Gregorlis textbook on rhinology and the Chu Palmer one are probably the best ones. But in the world of textbooks, I think, Simon, you summarized it. Textbooks now are out of date by the time they get into print. And I just think the world has moved on. You know, when we're sharing information, we just don't do it that way anymore. I think if you're relying on sort of encyclopedia type textbooks, it's a great reference they are. They're often not up to date. And, you know, they just take so long to compile these days. Okay, so Simon, what about we do then a prelacrimal? Was that the next thing on the agenda? And do you have any questions about that while I'm there?
People have been asking which cases do you use Carolyn's window on, but I mean, you've that it's
every time I do a draft 2A.
Yep.
So good, you know, isolated frontal disease, central compartment atopic sinus disease, anytime I want to expose the frontal recess because I'm doing a tumor and I don't want to get obstruction. If I'm doing a unilateral CSF leak, that'd be a great reason why I might do a Carolyn's window. Because look how well you can see the skull base from front to back here, you know, and you can even look in the cribriform on the medial side. You've just got full access, and you know that you could probably do any repair you like. You're not going to cause any secondary sinus dysfunction, and you certainly it's not going to elude you.
What do you put in the middle meatus in the procedure in a human?
In this sort of style sinus surgery, I just put a spacer, what's called a glove spacer. I still love the glove spacer. There's many different products around that, you know, are similar, but you need a bit of pressure, something solid here, to sort of hold all this. This will be very stable, but you've got to sort of hold it there in the first 7 to 14 days. That's about the time my spacer sits in. I don't use dissolvable ones. Sometimes I'll put some dissolvable gel or foam up here. Some of the gels are very nice, but really just a spacer, Simon, is all I use. And I have the spacer just sitting just anterior to this point here, so that when I pull it out, the edge of the spacer is not behind my flap. I have it sort of sitting over my flap edge. You don't want to accidentally pull your flap out. I know
what spacer you use, but the other APOS participants probably don't. So, I mean, it's a very simple spacer you use. How do you create it?
And once again on my YouTube channel, there's a nice video of making a spacer, and it is a Miracell sponge. You know, there's a couple of Medtronic make a very nice one that's 8 centimeters, 10 centimeters. You can either use that in about a 3/4 length or a half length, and then I cover it with a 5.5 or 6 glove finger, usually the little finger or the pinky, and then I tie it with a 4-0 Proline. And I use the 4-0 Proline with little ends on them so that I can pull them out later on. You don't have to use Proline, you can use silk, but and some people don't suture the ends. I suture it through the septum. I just find it easy, but you could easily, I think, just leave the Proline hanging in the nose or the silk hanging in the nose, and that'll give you something just to grab post-operatively, and then you just pull and the whole thing just slides out. It just means the cavity behind it's very moist, Simon, and you just do a little bit of suctioning and then you're done, you know. And usually patients, you know, I see them at sort of 1 to 2 weeks.
There's been a question, you know, do you coat the glove in Kennicomb or anything?
No. Look, I coat them in mupirocin ointment, but I think that's just probably a bit of magic dust. I don't think that's really necessary.
Yep.
So let's talk about a prelacrimal. If you're going to do a prelacrimal, you're going to create a U flap hinged at the level of the middle turbinate. You come really high, right down to here, right onto the piriform. It's so important to make a giant flap. Once again, the bigger your flap, the quicker it will heal, the less swollen it will get, and the less abnormal it will become in the post-op period. Once again, little cuts across here, to me, just end up creating problems. By making a giant flap, you hide it as well. What were you going to say, Simon?
Which cases would you use a prelacrimal approach for?
Anything where you've got a benign lesion on the floor of the nose and you're not going to drill the maxillary sinus too much. So if you can take out like a dental cysts and things that I have to chase that are going to be managed endonasally, I love doing it this way. Extensive IP, I wouldn't do it this way because I don't want to leave behind a really big raw area that has to heal by secondary intention with a lot of mucus dysfunction behind just a closed cavity. You know, so I really I do this where I'm just going to do something very limited. I know Bing Zhao uses it to go into the infratemporal fossa, which I think is a good example where you're not doing too much in the actual sinus. You're just using it as a way of getting there. So there you go. So I think that's pretty good. So you make this giant flap, then I'm going to get my freer, and it really is the whole wall, the whole floor. Okay, I'll swap to, as soon as I've got my plane going, I'll swap to the blunt here in a moment. It's like a bit like a giant DCR flap, isn't it, Simon?
Yep.
So,
I think, you know, your thing is that everyone gets scared of big flaps, but the bigger the flap, the better the success, the broader the vascularity.
and you can see how I've oversized it here, so it came right out over here, because it always shortens a little bit.
Yep.
Now, as you do this, Simon, and we fold it back, you'll see here in a moment, that'll fold back, but look where it's getting held up.
Yep.
And of course, that is your membranous duct.
Right.
So what we're going to do now is we're going to remove this crest.
This is what a lot of people miss. They don't remove the crest, so you just don't get the exposure that you need.
Yeah, you just need to remove the crest. Because one of the best instruments here to start this case is not a drill, but a kerrison. And it's going to accept my 3 kerrison. Amazing. And it's a bit like starting the DCR. You're going to do it from below. And I really go for it here. Now, someone said to me once, Simon, oh, you can't do this if it's too tight. Look, I heard that being said about the original descriptions of prelacrimal, but I think it's a little narrow-minded in thinking. You know, it's all about the angle here. You don't have to go into the space in front of the lacrimal duct. You can just go here where the lacrimal duct is if there's not much room between the duct and the anterior wall. And when we might actually go back to my CT scan in a moment, Simon, and why don't we talk about that? Because I think that's a really important issue. You can see here how I'm mobilizing the membranous duct. Can everyone see that? That's pretty clear, isn't it?
And it creates space even when
it's tight.
Say it's tight. Yep.
Yep, exactly. So let's have a look here. Let's go to the CT scan, guys, if that's possible. Is that going to create a technical issue? Can you see my scan now, Simon?
Yep, you got the thing. There's a question come through. How do you know where the piriform aperture is?
We're going to find it. Oh, so I know actually, maybe anteriorly I'll talk about that here in a moment. So let's come down here, Simon. Actually, look here. It is actually quite tight between the piriform of the front wall and the lacrimal. Don't you agree?
Yep, but you've created more space than that.
But I will. I'm going to drill essentially where the duct is, not in this little tiny pre-duct space. That to me is not a pre-lacrimal approach. The pre-lacrimal just means that your angulation you're taking is in front of the lacrimal system. Now, we're going to come through this section here, having mobilized the membranous duct out of the way. So let's go back to the video now, view. Good. Someone said to me, where do I find the piriform? Well, you just feel the upper lateral. Can you see that, Simon?
Yep.
Just feel it. That's hard bone there, and then click. It's the end right there. Can you see that? Hard bone and click. So that's how I know where the piriform aperture is when someone said to me, how do you find it? So you're absolutely right. You need to know where that is when you're doing a flap in a Carolyn's window, and you need to know where that is when you're doing a prelacrimal approach, because you really want to come all the way forward and really maximize that whole area. Now let's have a look now. Exactly as Simon was saying, we're going to create our space, right? So I know that here is safe, right? I'm not going to come into the canal or anything else. And you really want to keep a nice broad front when you do this. So it's nice to see your opening, but this bone here, you've got to keep it nice and broad, because in it will lie the anterior superior alveolar nerve. So just like when people did Denkers, you don't want to prang the anterior superior alveolar. It's okay if you expose it. I'll see if I can get a better view. I think you see some soft tissue in the bone there. Can you see that?
Yep.
So that's the limit of my dissection. You could take it more, but you're just going to get some dental numbness if you go further than that.
There's no
I guess that depends on what you're doing, right? If you're doing a big tumour or something, that may be something acceptable. But if you're just going in for something benign, you don't want to create unnecessary numbness.
And that's one of the criticisms of Kenon Fossa, isn't it? You know, I know Uresh Naidu did the
And this head's had some dental work done, so we might see that actually. That's a pretty nice view, Simon.
Yep. The important thing is you can see the anterior wall.
Exactly. That's the most important thing. This is an approach. Here we are now, right? There's our window. We could even come up a little bit higher. I've left it a bit short because we come right up to the orbital wall. Now you can actually see where the V2 comes out. You can see V2 coming here. Then it comes out here. You can see the anterior wall just there. There's anterior wall. God, so close, right? And look, there's our dental abscess that we can get into, right? It's been done by already. These heads have been used by a dental group before us. So there's where your molars are. Now look at this though. This is the best part. Once you do a prelacrimal, you actually makes you realize how much maxillary sinus exists before you get to that little tiny opening. So that's our antrostomy. But look how big the maxillary sinus is. Zygomatic recess. There it is there.
There you can see the nerve running along that anterior wall further down, just below your curette.
Yep. So that's the V2 nerve.
Yep.
Beautiful. Okay, you can see it there in the roof. So that's a prelacrimal, and then when you're done, you just use whatever use the portal, make it bigger or smaller, whatever you need. And then I put one suture in the turbinate. So one suture goes to here, one suture goes to the turbinate head to here. I put one or two up here, and then I usually try to grab this corner, and this corner comes to here. I put a little bit of gel foam just to pack that down, Simon. I allow it to release here, and then I put a silicon sheet, a 0.5 mil silicon sheet over the septum.
Yep.
And I might just put a little spacer, or maybe even a dissolvable material. And I usually do an antrostomy whenever I do this, just so that I always got a way of looking back into the sinus, washing the sinus out. I wouldn't do this without doing an antrostomy, but that's all I do, just antrostomy, and there you go. And if we do this technique, not because we're trying to avoid empty nose or something crazy like that. I mean, people have empty nose, right, have a hyperventilation disorder, nothing to do with surgery. We do it because if you can preserve this mucosa, they don't get any crusting in the nose. They heal very, very quickly. And that's one of the advantages of doing that technique. Now, why don't I do then, maybe Simon on this side, a modified medial maxillectomy? What do you think?
Yeah, I think so. And I mean, because your flap technique for that's very important.
Yeah, okay, that's a really good point, actually. Bring up the flap. And then I think on that note, this will be our last technique, unless someone wants to see me do a Lothrop, because I only plan to talk for an hour. So here we go here. So the first thing I do is that usually with an artery clip, do we have an artery clip? What if we do? Because it'd be nice to show what we do. Give us a second to pause here. We'll see if we can find a curved artery.
So there's a question here for the prelacrimal approach from maxillary tumour. How do you scope surveillance? And that's probably a really good question. So
yeah,
a reason not to do it.
Yeah. So if you just got a benign mass and you're happy just to look through the antrostomy with a flexible scope, then that's fine. But if you're if you're removing a lot of the mucosa of the maxillary sinus, a prelacrimal will not work for you. It'll leave behind a sinus cavity that's raw, it'll contract, it'll collect mucus, and especially if it's a tumor and you want surveillance, and that's not what I would do a prelacrimal for. Prelacrimal is where you're going in for like a periapical abscess, a dental issue, a foreign body in the sinus cavity. You just want some anterolateral reach to chase something. And in that situation, you've really got pretty normal mucosa in the maxillary sinus. and you're sort of committing to the idea of just looking through with a flexible scope. But if you've got an atypical tumour, certainly a malignancy or something like that, when you would never do anything like this. Even an extensive papilloma, I probably wouldn't do a prelacrimal for.
And how do you manage the inferior turbinate? Do you raise it, reflect it, or do you actually debride some of it just to...
What's this for? For this?
In the prelacrimal.
Oh, I just reflect it back exactly as I showed you then.
Yep, great.
Okay. So, next one here is, you just don't touch the turbinate. You make your incision in front of it, whole thing goes back, and then you put it back again. Now, so when I do a modified medial maxillectomy, it means, the modified bit means I'm trying to preserve the lacrimal apparatus. So what I'm going to do now is I'm going to place, usually you've done an antrostomy, I'm going to make a little crimp here. Making the crimp's important because in real life, that area will bleed on you. Then you want to cut that off and you want to leave the crimped area, obviously, in the patient. Now, as you come back now, if you can with a pair of scissors, I'll fold this back. Now, quite often, this will be quite chunky in patients, and you won't be able to simply just cut through it. And so one of the tricks is just simply to push it up and have it vertical. But if you can, and there's enough room in this lovely cadaver head, you can just take it off now. And if you take it off, as you take it off, don't take it off absolutely flush with the bone. Leave yourself a little stump, so if you get some bleeding, you don't have a situation where you can't bipolar the bleeding spot.
Because it comes out of the bone.
Thank you. Yeah. Looking for my Blakesley. Keep all this, always keep the turbinate. You'll use that as a graft later on. Now, Simon brought up a good point. You know, Simon and I, whenever we try to operate, we try to preserve mucosa, right? Let me take you through where the lacrimal apparatus is, and the flap is part of that. It's really the Woodworth flap. You know, we have to give a shout out to Brad, who really popularized the inferior meatal flap. I'm trying to get my view just perfect, because you need a great view to show you what I'm going to show you next. Okay, there you go. Why do I feel my view is not perfect there? There you go, it's better. So can you see that little slit?
Yep.
That is the valve. I forget which one. Rossen, Muller, what is it? I've got our trainees behind us. What's the valve at the very bottom? Hasner, thank you, Hasner. I always get it confused. What's Rossen, Muller's? That's the one at the top, isn't it? Maybe not even part of the lacrimal system. Now, so when you make, with a needle point diathermy, you make an incision that's 45 degrees. And I'm making this anterior one first, which I don't actually do in real life because I do the posterior one first. But I'm making this anterior one first just to show you. And you make it at 45 degrees behind Hasner's valve. And then forward like this. It's very important to make this at 45. It's not a 90-degree flap. Now, next one, you feel for the soft palate, there's soft palate. Then this one is 90 degrees. It's going to dissect even without me trying. And the whole thing comes off. Look, it doesn't happen like that in real life. You've got to dissect it. And also, you have to make a 90-degree cut. But with a diathermy, it's lovely. You'll have to just touch me on that. Okay, so next one here is with a curette, you're going to do a maneuver called Jess's punch. So Jessica Grayson, a fantastic rhinologist, works at UAB. There's nothing delicate that she would do in the sinus cavity, and the Jess's punch is a great technique. She saw me how I used to come down through this, up through it, drill. And she said, and when I saw her operate and just do it, she just said, look, for heaven's sake, just go through it, like that. And so what we do is we do that Jess's punch now. You just push straight through. I think it's a great idea. And then when you come in with a kerosene, you just go straight into the Jess's punch spot. You bite straight up. You then get your straight through cut. And then you get a backbiter. I think the dissection has to end, Cara. The instruments will become such a salad there in a moment that I don't think we're going to be able to continue. And I take that now. That is not, I can stress to you, not a medial maxillectomy. That is just a hole right now. So what we need to do is, in order to get access here, we're going to make sure that flap's out of the way. We're going to drill this little wedge of bone. See this wedge of bone here? We call this Snidvong's wedge. Snidvong was a Thai surgeon, and you've got to get this wedge of bone out. If you don't get this wedge of bone anteriorly, you can't really put your instruments in. So there you go now.
He's probably online listening to you.
Oh, yes, he's listening. There you go, of course. You've got to get Snidvong's wedge off. Very annoying is Snidvong's wedge if you leave it up there.
I think the reason Richard's doing this is you don't want to sump.
Yes. Explain that, Simon.
So you've got to realize that what you're doing is you're altering the drainage of the maxillary sinus by doing a medial maxillectomy. And the maxillary floor is often a lot lower than the floor of the nasal cavity. And therefore, if you've got bone sticking up, it's like a fence that the mucus has to come out over, and it just doesn't do it. So you're going to get crusting, you're going to get secretions living in that maxillary sinus, and essentially, somewhere like Australia, you just get it colonized with fungus, and you get a massive iatrogenic fungal ball, essentially. Yeah,
it's absolutely true. Once you start doing medial maxillectomies in your repertoire, you're doing it for people who either have a failed sinus cavity, they've got end-stage inflammatory disease, or you're doing something terrible in there, like taking a tumor out. And when you do something terrible, Simon, like drilling all the mucosa out and everything else, it's great when functional returns, but it doesn't always, right? And so if the function doesn't return, you just got to be prepared to how to manage a sinus cavity in whom the function may not fully return. Now here, you can see that I've just got a little lip of bone which I don't like. And what I would normally do, whether I'm doing this as part of a tumor surgery or at the end of a sort of inflammatory case, is I will raise that mucosa. Can you see me raising the mucosa?
Yep.
And I will strip the mucosa off the floor. So even if there was a little bit of mucosa there, you know, usually it's very thickened. It's not, see how thin it is today? It's super thin today because it's normal. In patients that you're doing such a procedure for, if it's for inflammatory change or chronic maxillary disease or sumping, you'll end up with this very chunky mucosa, actually. And the very chunky mucosa becomes very easy to raise, actually. The thin mucosa here is actually a little bit tricky to raise in one piece. But you can see me raise it there. So I would normally raise it like that, Simon.
Yep.
And then the flap goes in. I sometimes fill this with a bit of gel foam paste. That's the other trick. And then if I fill it with gel foam paste, I'll fill it with gel foam paste, then put the flap on top. So actually it sits like this. And if you go to our YouTube channel once again, you'll see how that sits. You know, it sits where it really just becomes level with the floor of the nose. That's one of my goals, to avoid the sump or pocket that Simon's talking about. And care once again, Simon, as the descending palatine as you described. And a little bit, that's going to annoy me in a second, so I'm just going to stop. And then here you go here. I might take this bone down a little bit. If you get close to the descending palatine area, sometimes it's good just to grab the bone rather than drilling it, because it will naturally fracture at that level of the descending palatine nerve. And you can see that there. Here, that's the nerve. So by grabbing the bone and fracturing it is a great way of just making sure you don't accidentally roger the nerve with a drill. You stop. There you go. And not bad, pretty close to a medial maxillectomy. And I do use a medial maxillectomy a lot to get access to the infratemporal fossa. And I'd convert this to a total maxillectomy, medial maxillectomy, if I wanted or more lateral access again. And very rarely do I ever remove the lateral, or the medial buttress, I should say, or the lateral border of the piriform. This medial buttress bone, as it's referred to, you know, if you do drill it away, you can occasionally get a little bit of alo groove or depression. So over time, not in the first few months. So that's a modified medial maxillectomy. And then, Simon, I think maybe if I do a Lothrop, I think that's it. But maybe we can take some questions while I'm doing a little bit here, and I might get our team now to go and dissect on their heads.
Any questions? Richard, we've had 177 people online, which has been
a great turnout.
It's possibly, you know, I don't know where there's been any more, you know, anything bigger than that, really. Okay, so what's the difference between a prelacrimal and a Denker's approach? Okay, so
prelacrimal, you know, I think it's a good point, Simon. Prelacrimal to me means you're doing the approach and you're returning the wall. If you do this incision and then just take everything off, including the mucosa, that's called a total medial maxillectomy.
Yep.
That's got nothing to do with prelacrimal. That's just old school total medial maxillectomy. So prelacrimal approach is where you're really creating this window in front or perilacrimally, and you're using it to get in with the idea of returning the wall and restoring the lateral nasal wall as just a way of decreasing crusting and morbidity.
Yep.
Does that make sense?
Yep.
That's a good point. Let's go some more questions. Keep hitting me out while I'm preparing the bone of where we're going to do the Lothrop.
Now, in terms of, is one from me. In terms of post-operative management, if someone's got extensive mucosal disease, what's your routine post-operative care?
That's a tricky one because I use the new EPOS 2020 guidelines as to describe what sort of CRS I'm using.
Yep.
So, like patients who have
T2, say someone got with T2 disease.
A type 2 primary diffuse type 2 disease, like eosinophilic CRS.
Yep.
And I just want to point out, for those people who are not familiar with the new classification of how we think about CRS, the EPOS 2020 group came up with a really good system, really simple and practical, and I really encourage you to have a look. It's on the EPOS website. There's a summary on our YouTube channel, but if you go to rhinologyjournal.com or .org, I think it is, you'll find the details there. It's just a great new part of the executive summary for the EPOS 2020. Now, if I've got a patient has inflammatory disease, you know, if you have an inflammatory disorder, your surgery is not going to cure that, right? You know, surgery is really all about setting the patient up so that they have a sinus cavity they can topicalize with corticosteroid irrigations, avoid mucus trapping in it, and also overcome any mucostasis. This is the goals in my mind. Now, of course, there's a few little things you might also achieve with that. You're obviously going to get rid of any barotrauma events and pressure issues, but really none of it is going to affect the course of the disease. The whole disease process, in my mind, is all about the post-operative anti-inflammatory therapy. So I normally would leave patients on post-operative corticosteroids only. They don't use them pre-op, and they stay on the post-operative corticosteroids until the sinus mucosa has normalized. That's somewhere between 3 weeks and 6 weeks, and usually. And during that time, you start them on a corticosteroid irrigation. I usually start them on a corticosteroid irrigation when the path results come back, you know, maybe somewhere between 1 and 3 weeks after surgery, and they're taking some oral steroid up to that point. So that's sort of how it works. I do give them some anti-staph antibiotics. I'm a bit old school maybe in that regard. So I give them some pyrrhicin ointment and some either cotrimoxazole or amoxiclav, and I do that only for 10 days. And I sort of think just in that first 10 days, it's very easy to get heavily colonized with bugs because you have all this old blood around, packing around. There's first olfactory neurone, of course, Simon. And so I do all that, but the most...
There was a little vessel in front of that, wasn't there?
Yeah, there might have been, yeah, and I sort of just buzzed through it straight away, yeah. You're absolutely right. Yeah, there's a little vessel that sometimes comes anteriorly, but that's the nerve there. That's the first for sure. You can see it's coming up medially into it, yeah. Okay.
It's important to realise that first nerve is actually quite a lot further forward than the anterior part of the middle turbinate. I've seen people, you know, presuming that the cruciform plate starts as soon as the middle turbinate, you know, sort of the anterior end, but it's not. It's much further back.
Yeah, that's a good point. just finding the dura as it folds up into the first fascicle, it's just a guide. You're not going to suddenly get a CSF leak or pop into the brain doing that. So you can do all that pretty safely. You saw that I found the cartilaginous bony junction. Just goes to show you how far into the nose I am. I'm really underneath the frontal sinus floor. And here I am now. I'm just going to take out that middle part of the septum in my window. Now, I've left my little mucosal flaps intact there. I might actually shave them, but I don't know if my suction's going to be working. We'll check it out very briefly. I'm going to put my suction on. Yeah, maybe it is, actually. I think there's just bone dust in my drill. Do you have another drill there?
So, share your experience in points for safely widening a window during the prelacrimal approach.
Now, for the purpose of this dissection, I'm just going to get rid of this mucosa, but by all means, there's little ways in which you can preserve this and the flaps and various things. So when people have seen me shaving it away, if it's very thin and normal and you want to preserve it, by all means, you can try to raise one of the many flaps that have been designed.
So, Richard,
yeah, someone had a question there.
Safety in widening the window during lacrimal.
Oh yeah, just don't want to pick up the. You can go back as far as the posterior or descending nerve.
Yep.
Descending, and you just want to anteriorly. Just to be always cognizant of the fact that your anterior superior alveolar nerve is going to be there anteriorly in that piriform bone.
And I think the other thing is if you're using a diamond, it's much safer than using a cutting burr.
Yeah, you can almost find the canal, the anterior superior alveolar nerve canal. Has it got some eponymous name? I don't think it does it?
No, I mean, and then if you accidentally cut the lacrimal duct, what do?
Oh, it's no big deal. You just clean cut it. Sometimes you will, you just clean cut the duct. I would say you don't even need to do a DCR. If you just clean cut it, it'll be just fine. For most people.
Someone's asked about local anaesthesia. I mean, I think you mentioned is ropivacaine, adrenaline, tranexamic acid.
Yeah, exactly. That one. There you go. This is better. I think I was just blunt on that previous shaver. So I would normally if I'm not raising the flaps, I will trim them back so they're nice and neat, so they don't get in the way of all our drilling. I use the same injection for everything: septum, turbs, FESS, you name it, all the same one.
Right. And is there, what's the actual difference between middle meatal antrostomy, large MMA, mega MMA, and a modified?
I don't know. I mean, I think some people who just sort of flake out the uncinate and things like that. I mean, I'm not sure what that is. It's an uncinectomy. An antrostomy to me is just removing the uncinate and the fontanelle areas. That's an antrostomy. I don't really do anything less than that. I think some people described what's called a mega antrostomy. This is, Peter Wong. They were talking about just dropping that down to the floor. But I don't think that makes sense. Most of us now would simply do a modified meatal maxillectomy, really come forward, expose the full anterior part of the sinus cavity down here, anteriorly down here, rather than just dropping the antrostomy down. And that's because you want to get to this little prelacrimal fossa area, get to the floor, like you said, remove the sumping area. And I don't think even Peter does that. I think he does like a proper medial maxillectomy these days. That was a very old article of his. Yep. Let's go and find the periosteum then, all right?
Yep. So this is the outside-in technique for doing a draft 3, which Richard's written up. It's a good pioneering article. Is it in IFAR or rhinology?
It was in laryngoscope, the original.
Yep.
And there's an how I do it in AJRA.
Yep.
So here's periosteum up here. So this makes this Ritter's triangle.
And this is why using the diamond is really important, because if you use a cutting burr, that'll bleed like crazy. Whereas with the diamond, you just expose the periosteum and you just keep going.
See, you can see the front wall, the frontal recess coming up. Someone asked me, how far do we take the septectomy? I don't normally take the septectomy much lower than about the upper third of the middle turb. You want to be able to see the other side. I see the periosteum. You want to be able to see the periosteum on the other side.
Yeah.
And sometimes if there's a big swell body, high deviation, I'll take that as well, just include it in the septectomy. But I don't do huge septectomies. I don't drop it all the way down here. I do try to keep it in the upper third.
The crustal more would be the one.
It doesn't help you necessarily. It's the drilling. The drilling of the bone is what holds most people up. So once I've got periosteum exposed here and here, you just remove the stuff that's in between. And I found my frontal recess down here. It's a little bit funny because I've got one side open.
Makes it a bit easier.
Yeah, but you shouldn't. I'm intentionally not using that, right? Because I want to show you, it's not about that, right?
It's a frontal beakectomy, as you describe it.
It's a nasofrontal beakectomy, exactly. It's this thing you want to remove, this bone. And often, the drilling is easy in this case, It's just got this bone here, you can drill it all out. And you just drill, and then all of a sudden, when you think, oh my God, I'm in solid bone, you suddenly start to see this.
Yep.
The frontal sinus mucosa.
That little bubble is a nice relief when you see it.
And then don't go into it, just try to drill above it and expose around it, because you don't want to go in low. You don't want to change your directory and suddenly go in low. And then when it gets super thin, then it is best to drill with the equator of the burr. Equator of the burr is always more efficient than the pole. There's always a bit of pole drilling, unfortunately, in sinuses. And so you try to avoid it.
And the important thing is always visualize the tip of your drill.
Yeah. And I'm doing everything from the right nostril at the moment. I might swap that over. Might get a better view here in a moment if I just swap over.
So do you use IGS to identify the anterior border of your flap?
No, not really anymore. But it's a great tool. I think if you're just starting out doing this, it's just such a great tool. Okay, there you go there. I'm just going to quickly get some suction.
So in a virgin draft 3, before the superior posterior septectomy, what would be your first step?
The minimum you have to do is an OMC operation.
Yeah.
So you've got to do an OMC, and I'll do that occasionally, 2 bilateral OMCs.
Yep.
And then I'll drill straight up, and I'll do that sometimes to bail neurosurgeons out when they get like a little leak after a frontal craniotomy. That'd be a really common scenario of doing that, where you're going to be doing very little. You don't need to do a whole posterior ethmoid dissection, and you don't need that much access. So you can see here now we've got this very thick bar. Here's the intersinus partition. That's the sort of left frontal in its 2 components, lateral and medial. And then you've just got this thick bit of bone here. And you've got to get rid of all this. I can't tell you. This is where, once you're committed in a Lothrop, you just have to really get rid of it. And look how nice high-speed drills these days just make this process so much easier.
Like a knife through butter.
Remember we used to do courses, Simon, and we'd have like a drill. And it'd take us a while to do a Lothrop, and we'd have to worry about, is that too long to show on a dissection, or all of those times.
You often pre-prepare the cadaver and do work before you actually did the demonstration to save time.
Yeah, amazing, And now just connecting all that now at the end, piece of cake, right?
Mm-hmm.
I'll take that into sinus partition all the way up. Okay, let's go back.
Is that a straight drill?
15-degree drill, and we are still using a 0-degree scope.
Yep.
Let's come in through this side. And of course, I haven't done my frontal recess dissection on this side, although I have on the other side.
Yep.
And I'm going to get my wipe up now, as we're coming up towards the end of our dissection.
So you don't really need these big angled
No.
and you don't need a 30-degree or 70-degree scope. So, vast majority of it can be done with a 0.
Exactly. I'm sure you'll find patients in which the anatomy is such that you think you just to finish it off. Like here, you can maybe little bit of angle. I'll get it though with a.
Yeah, just take.
I'll do some over and under.
If you take the beak back a bit further, you usually get there.
Yeah, that's right. Just take the beak a little bit further. And like you can always finish up at the end here with a bit of using like a baby Hoseman or articulated punch. I've got one of those actually here. I'm going to grab the articulated punch and show you how.
And can you show us how low you take the T, the frontal T?
Oh yeah, that's a good point. There's the first olfactory neuron. Can you see that?
Yep.
So I would take this down even lower. So if I wanted to show you here.
With a diamond burr, you're really not going to cause any problems.
Yeah, exactly. And often you do have these funny little intersinus partitions and things just here.
There's often a cell there, isn't there?
Yeah, exactly as you picked it, as you called it. And Simon's absolutely right. There's often a cell. And you know what this is, Simon? What we're staring into? This is the pneumatization of the cristagalli,
Yep.
which you often see.
Yeah, I've got a patient with an inverting papilloma in one of those.
Yeah, and I've dug things out of there before. We'll have a look at that. See that little pocket? Sometimes that'll go right up into the crista. So now, obviously, you have to connect the rest of your frontal recess dissection off, which I haven't done for the sake of time. But if you wanted to use like a little baby Hoseman or an articulated punch, you could finesse the wall here. But you can see I don't have much wall. I'm there. Yep. And I've already created a long, wide opening, but one of the rules that we call it is that when we square off the edge, you should be able to get a curette at the end of a Lothrop. You should be able to put the curette in the nose. The curette should be able to touch the apex of the frontal sinus. Can you see that? Mm-hmm. You should be able to follow the medial orbital wall and touch with the curette the roof of the orbit. Can you see that? Straight curette. And we should be able to do that on both sides. All right, so all the way at the top. Here we are now, and essentially there's the roof. So, and I do drill those partitions all the way up. Maybe if I was a real case, I'd maybe trim that down a little bit. Although we're pretty close to the front wall there.
Yep.
Yeah, don't you think? Maybe just really make sure that partition's back. Yeah, that looks pretty close though to what I do. But obviously, I would connect all this up.
And I think the other thing you showed very nicely there was the use of the punch. It does speed you up if you just use the punch to get through a lot of those big, thicker bits of bone. It just saves you time when you're drilling. Yeah,
and there's always like the people that have that amazing frontal sinus cavity where they've got a really thin floor, and you can do 50% of the frontal with a punch. People who tell me I always use a punch and that's all I use for my Lothrop, I'm not sure they're getting this sort of view with the 0. See how you can see the anterior wall?
You can't take out the whole beak with a punch.
Yeah. Now let's have a look. We'll go back to my we'll go back to the CT scan here in a moment, and I might just have a look and see if there is that pneumatization of the cristagalli.
What speeds that drill is a question.
Yeah, there he is, right there.
Yep.
So you can see on the coronal.
Yep, saw it. What speeds that drill, Rich?
30,000.
30,000. Yep. Makes a big difference, doesn't it?
So I'll just put my cursor on it. This little area here on the CT scan, can you see that?
Yep.
That's that little pocket. If you go back now to the endoscopic view, that's this area here.
Yep.
Yep. And look, Simon, I think it's been one. Is there any other questions that we want to maybe discuss with the audience before we wrap up?
No, Rich, I think we've probably, it's probably one of the fastest whiz through of all the advanced FESS, sort of dissections that I've ever seen. But it's been a fantastic experience actually doing this online. So just before we wrap up, any last minute questions, please fire away. We will be recording this and putting it up on the APOST website. And I think on behalf of all the APOST team, I'd like to thank Richard and everyone in Sydney that's put this together. I think the IT support you've had there has been fantastic, and just it's run seamlessly. So thanks, Richard.
Thanks very much.
And also to Bonnie, the APOS secretary, for coordinating all of this, and to Kelvin, and to Olympus, Medtronic, and all our other sponsors who allow this to happen. It's been fantastic that APOS gets the support from industry. And also like to thank, Michael Tong, Jason Chan, and Journaling from Singapore, all the other APOS members, Corncat, Prepper in Malaysia, and everyone else that makes APOS so successful. So I hope we can see some of you in person during 2021. We're still not sure exactly when we'll be restarting live APOS courses, really just would like to wish you all a very festive season, and thank you again for supporting APOS. So if there's any more questions, please flick Bonnie an email, and either Richard or myself will do our best to try and answer them for you. So thanks for dialing in, and enjoy the rest of your weekend. Thank you all very much.